Start. Yes, hello everyone. Good morning. This is Dr. Khan, Executive Plastic Surgery, Bloomfield Hills, Michigan. It's a pleasure to be on again and do another Facebook, YouTube, TikTok, and Instagram Live. It's a pleasure to be talking about what is a very important topic, what is breast implant illness. And so a lot of productivity this past week, a lot of interesting patients from Tennessee, from out of state, from Florida, and a lot of follow-ups from patients that have been operated on. I get this question asked a lot: is it safe for me to travel? Do I really have to go out of state to basically get the surgery? I just literally 10 minutes ago, I just finished a follow-up with one of my patients from Alabama, and she's going to be our Facebook guest live in the next couple of weeks, and you will hear directly from her. Remember, this is a surgery where the surgeon's mindset is extremely important in order to understand what his or her philosophy is, what is her mentality when it comes to breast implant illness, what is it that he or she is thinking, and that you need to have felt that comfort, that confidence, that satisfaction. And I'll tell you that respect, if you will, that you need to be taken very seriously. Each one of your words needs to be looked into. And ultimately, there is only one bod, one interest. And this is in my practice, where I want to make sure that you get the best surgery possible without unnecessary exaggerated surgery, and that there is only one confidence, that is to get you healthy and better, and at the same time making sure aesthetically you are in the best look after the surgery. And this hopefully is your last surgery, and this is what I strive for. So you have to understand the psyche of your surgeon. You have to understand the confidence. How many patients this week that came to me from out of town that said that I really know you, it's good to see you in person, it's like I've seen each one of your videos twice, and this is part of that informed consent. So in my practice, as you will see, the goal is to remove that entire implant capsule and all of that inflamed tissue completely, sincerely, definitively. So that one Facebook Live that I did on the 29th of January, and I want each one of you to absolutely see that, because we have seen it many times in the years past and in the many months past. You never know what is going to be within, what are the internal contents of that capsule. That is what is within the capsule. So in this case, on the 29th of January 2025, this was the one Facebook Live that I did directly from the operating room. This was a saline implant, supposed to be the nicer, better, safer implant. And there were 87 cc's of yellow turbid fluid within the capsule, outside of the implant, not the implant ruptured. So this was an intact saline implant with 87 cc's of yellow turbid fluid around, and this was done en bloc. And so this was that fluid. Had there been a break in the capsule, it would have absolutely leaked out and would have been, quote unquote, a catastrophe to manage. A few years ago, I did a similar case where that fluid turned out to be an abscess. So the patient actually had a walled off abscess within her chest, in between the implant and the capsule. And as you can imagine, had that spilled into the chest, that would have been sepsis, fevers, a very sick patient. And so this is where you never know what you're going to find. And in majority of the cases, as you have seen over the past few years, a ruptured silicone implant, you do not want to be finding out that you had a ruptured silicone implant to your surprise, or to your surgeon's surprise. So one has to always assume that the implant is ruptured. And remember, they are not lifetime devices. And so going back to the point, why do I have to travel? We will hear from our patient from Alabama. She was saying, I'm so glad I traveled, and she got her surgery. And you know, anyone who gets their surgery, they have that two levels of confidence. Number one, that if the surgery is done today, you know that the entire implant capsule, all inflamed tissue, is removed completely, sincerely, definitively. And that number two, that all of what was removed was checked to make sure it was not that very rare BIALCL, CD30 analysis was done, cultures were done, anything abnormal was also removed. So if you go back and look on the 29th of January 2025, just 3 days ago, that case There was inflammation that was directly on top of the rib. So the end block had been done, the implant capsule was removed, and now I went back and I checked and I looked around, and directly on top of the rib, in between the rib, the intercostal muscle fascia, that tissue was removed because I didn't like the way how it looked. It looked definitely inflamed. It did not look healthy, and that was part of the culprit. So that tissue has to go as well. And in my practice, I find that is key. 3 weeks ago, I operated on a nice lady from Austria. She already had her explant. She already had done very well with the pictures. Her European plastic surgeon had definitely, at least in my mind, in my eyes, I have seen the end block pictures, and she had the end block done. But it was that tissue around that I removed for her, that inflamed tissue that certainly has led her in an improved state clinically, physiologically, and we'll hear from her again in the next few months so that we can learn from her experience. So again, you want to do the surgery, right? This is the take-home message for this year. My very first consult this year was a physician, an ICU intensivist, an emergency room doctor who actually had her explant done by a major notable plastic surgeon who works at the top 5 hospitals in the country. And her surgeon felt that the capsules were relatively thin and they could be cauterized, so they were not physically removed. And it was an incomplete job. And now she has that task, that challenge of coming to me, and she needs to have that residual capsule removed plus that inflamed tissue such that she gets the best chance to bounce back. She is only 41, and this is where the whole goal, and in my practice at least, we see that this is the entire inflamed tissue must be removed, number one, and number two, it must be all checked. So going back to the point, 9 out of 10 patients come to me from out of town. This is where they have done their homework, and this is the take-home message. Number one, do your homework, do your reading. This is part of the informed consent. Follow me on the YouTube, Facebook, and you will see how I do it, why I do it in the con procedure, where you have majority of the times no lift is required, no drains are needed. I have not placed drains in well over 5 years. Number three, I take high definition pictures and videos of the chest wall showing complete removal of the capsule. That's the most important thing, if you ask me, where your surgeon is showing, vouching, and proving to you that the chest is free of the capsule and all that inflamed tissue, and only good healthy tissue remains behind. So you have high definition pictures, videos of not only the chest wall but also the cutting open of the capsule on the table. Number four, the capsules are sent to pathology to rule out that very rare BILCL. Number five, you have cultures done for bacteria and fungus. Number six, the twilight deep sedation, where the patient is not paralyzed and the ventilator is not breathing for the patient, and this has been consistently done relatively very safely, and the patients have no recollection of the surgery. And the next thing here is the implants are returned to the patient. The saline implants or the silicone implants, so the patients know what was inside, what was the volume. Just this week alone, I returned the implants to a patient, and she said that these are much larger than what was discussed. So you want to return whatever was removed. And number eight, regardless from one patient to the other, all patients get the same surgery. So a couple of weeks ago, I operated on a lady with a BMI of 49, and so she had to be done at the hospital, and she got the same surgery. I did the Facebook Live a couple of weeks ago on that Tuesday, and she got the same surgery that all my patients got this week. And this is the same level of care and sophistication. And it is certainly very safe to travel. And this is where between the twilight deep sedation, between the SCD boots, which are the sequential compression devices on the legs that pump and circulate blood, between the compression socks that all of my patients are wearing, and number four, between the heparin shot that every patient gets, which is 5,000 units of sub-Q into the subcutaneous area, and number five, the twilight deep sedation, where the patient is not paralyzed and the muscles, the tone is maintained, so there's no pulling of the blood. And number six, I have the patients out of bed to chair on the day of surgery. and the following day they're up and about, and it is required that they walk. Certainly it helps with their meditation, the breathing, and again, the only activity the patients are allowed is basically getting up and gently walking. No exercise, no treadmill, no vibration plate, no yoga, none of the Peloton. The only activity you're allowed is walking on a surface gently so that you're not upping the heart rate. This certainly helps with the breathing, circulation, with keeping the gut movement, and also helps with the recovery where you release endorphins and you have a better rate of physiologic return versus, let's say, if you're sitting down. So very important to understand why and how I do it in the manner that I do. Now, if any of you have any questions, please feel free to ask. We will try to do this on a weekly basis. If you have any questions, certainly I'm available to answer any questions. Remember, this is part of the informed consent. I encourage the patients to go to other plastic surgeons so that you can understand why or why not. It only reinforces you indulge yourself in this process, and as you will see, it doesn't take much to realize. There are only like 15-20 questions that one can ask. A few months ago, I did a series of question and answer sessions. Mark, if you can give me those questions. So if you go to my website, in December, I did a series of questions like rapid fire, common questions to ask your explant surgeon or Dr. Khan, explant surgery, all the details, all these small questions, which ultimately each question is a big question. Like, are you board certified plastic surgeon? That means you've gone through the professionalism, the right training. It's not on the job training. There are some surgeons, believe it or not, right here in town who have general surgery training. One of the patients came to me from, I believe, North Carolina. She had a general surgeon remove implants. As you can imagine, this is not standard of care. I have had other ENT surgeons vouching to removal, and certainly a lot of ENT doctors who are placing implants, emergency room doctors. So you want to make sure you're a surgeon and has privileges at the hospital. So that kind of reinforces the fact that your surgeon is board certified and has privileges at the hospital, because the hospital credentialing committee continues to follow you and continues to make sure that you have kept up with the standards that one must have in order to continue to do what is very safe, effective, practical plastic surgery. The other thing that you need to see, you need to get the internal 100% confidence. Sometimes two minds are better than one, but you want to have the absolute confidence that your surgeon's only interest is you, so that he or she is not trying to sell you 5 other things, where the goal of the surgery is to remove that entire implant capsule and inflamed tissue completely, sincerely, respectfully, religiously, and that there is no other motive, there is no other exaggerated sales, there is no exaggerated unnecessary lifts. You will see the many patients, including my patient from Alabama who's going to be on. We will hear directly from her if she needed drains, if she needed a lift. This is a question I want to go ahead and touch base again on: do I need a drain? And as you will see, this is kind of a very heavy question, but I will go ahead and answer it. If you look at, there's 3 ways to answer. Number one, if you look at my many patients who have had the surgery, you will see that they do not come to me or go anywhere elsewhere outside to another hospital and get drains. So number one. Number two, if I'm removing all of the bad tissue, inflamed tissue, and all of that tissue, i.e. the capsular tissue, inflamed tissue, the entire burden is removed and only good, healthy, viable tissue remains behind, the need for the drain is certainly not there, because there was no spillage of the silicone, there was no capsule left behind, there was no spillage of that fluid. Imagine if that Facebook Live, which I want you to see, the saline implant from a couple of days ago, the 29th of January, where I had that 87 cc's spilled into the chest. Clearly, the patient would have needed the drains, and the patient would certainly have to be admitted post-op too, because for monitoring, because we do not know what the consistency of that fluid would be. So the drains are required if there is badness left behind, and in the case where the surgeon is removing everything and the blood loss is less than 5 cc's in well over 99.5% of the time, the need for the drain is not there. And number three, the surgeon is taking his or her time to dissect so that the muscle is not cut into unnecessarily. The tissue planes are respected, and as you will see, majority of my patients, they do not take much of pain meds, maybe 2-3 days, if at all. And the patient's pain requirements are certainly very within normal limits, if not even required in a good number of the cases. And so you will see the drain requirement is not there. Now, conversely, I will say the burden lies on the many surgeons who are always using drains in all the patients. Because look, I have it, and this is I presented in May of 2023 at the World Icoplast Conference of my 1,000 explants, and I said I only needed drains in 7 of my patients. And this is consistently I've shown, and I'm happily presented that there was no need for the drain requirement when done in the manner that I have described. The other thing I want to mention is in the latter part of March, my office is going to upload hundreds of videos of the chest wall and the chest showing complete removal of the capsule. So you want to see those videos. They're going to be up on my webpage and also on YouTube. And these are all, once I've removed the implant capsule and all of the inflamed tissue, this is the chest wall that remains. And that is the most important video, if you ask me, that convinces, shows, portrays, and also with confidence tells the listener and the viewer that there is no capsular tissue left behind. I want you to see that yourself. Now, sometimes it might be a little bit hard to see, but remember, this is what you want to see. If someone gets their gallbladder out, we know that you don't need to see anything like that, or the appendix. But in this case, remember, the whole bond is where that capsule must be removed completely. And this is my practice, where you do not want to second guess your surgeon. You do not want to go back and say, well, did my surgeon get it all out? No, you want to have that firm determination as you go into the case that you know your surgeon's only interest is to get that capsule out sincerely, definitively, that your surgeon is a complete, total believer in breast implant illness. I will tell you, I've talked to many patients where their initial surgeon who had done the explant is still putting an implant, so that's a big red flag. Number two, there are no videos or high definition pictures of the chest wall or cutting open of the capsule. That's another big red flag. Number three, the length of the incision. One lady I talked to this week had an incision that was this small, and she had a relatively large implant. I will tell you, it is virtually impossible to basically remove an implant from a very small incision and do a proper end block or a total capsulectomy from a small incision, simply because you want to be able to visualize all the way medially, superiorly, laterally, and inferiorly, anteriorly, and posteriorly. So you're dissecting in the 6 dimensions underneath the muscle, so that all of that capsular tissue. And when you see the videos, you will see for yourself exactly what I'm talking about. The other thing you want to make sure that your surgeon is basically has a track record on social media that he or she is doing the surgery right, and that other patients validate. Nowadays, unfortunately, you have a lot of surgeons' own team members vouching and advocating, where certainly there's a lot of bias. You want to definitely talk to the surgeon's previous patients, and you want to have a non-biased view about why and how the surgeon is doing her surgery, and that you have with confidence that feedback. How many patients did I talk to this past week? They said they've been following me for over a year, for a couple of years. So this is where you do not want to rush into the judgment and say, well, I want a surgery with this surgeon because he takes my insurance. No, you want to feel very confident that your surgeon is a firm believer in breast implant illness, that she is talking about it. She is not putting in implants. She has basically shown the videos and pictures on social media. And that the other thing that I find very interesting is, I take almost 4 hours plus minus to doing an explant for an average 350 cc implant, plus minus 4 hours. Now, yesterday's second case, for example, was 520 cc's, and it went relatively smoother. Then the other implant that I had removed, where it was only 250 cc's, roughly half the size. Now it all depends on how the previous surgeon did the surgery, how it held up, if there was malpositioning, if there was capsular contracture, how much inflammation was there, if there was a rupture. And so there are many other factors that come into play when I'm removing, and I cannot tell if it's going to be relatively easier or straightforward surgery. So for example, the 775 cc implant that was ruptured that I did on the high BMI lady, the 49 BMI lady at the hospital, that was much easier than the surgery that I did on the saline implant that I believe was 300 cc's on the 29th of January, where there was fluid within the capsule. So these are, one is almost 2.5 times the size, and a high BMI patient, you would think that would be harder. So it just varies from person to person. In my practice, I find the best case scenario is a lady who is post-menopausal, small implants above the muscle, and with a capsular contracture, because the dissection planes are relatively much better defined. The muscle is attenuated. The capsule is relatively thick, so I have something hard and sturdy to hold against and dissect against. When it is above the muscle, there are no ribs to dissect onto, and the surgery is relatively much easier for the patient because the muscle is not involved. So this is my best case scenario. My worst case scenario is where a patient is young, in her 30s, where the muscle and the tissue planes, the connective tissue is very thick, the implant is large, the implant is ruptured, and it is plastered and super glued to the rib. And it can take me hours, 5 hours, 5.5 hours or so in those situations to doing the surgery. I never time and allocate exactly 4 hours. I tell my patients whatever length of time it takes. There have been times where, believe it or not, my second patient or third patient, sometimes when I've done 3 cases, they have waited 3 hours. And this is when we knew everything was going according to the plan, but this is how long it took for me to dissect off of the rib, because that inflamed tissue was much more involved. And while the patient was here, it just added to the length of the case. And this is surgery. You cannot predict exactly how it's going to go. I cannot examine someone and say, well, you're going to be like picture number 5 on this page, or you're going to take this long because you have smaller implants or large implants. Only till I get started do I only then find out what and how the surgery is going to go. Now, the other thing I want to talk about here is, I get this question asked a lot: what does my primary care doctor need to do? And I say your primary care doctor needs to evaluate you, and he or she needs to determine what needs to be done. If the EKG needs to be done, then if you're 30 and he decides that you do not need labs because they were done 6 months ago, then the labs do not need to be repeated. But remember, this is where the primary care doctors do routinely. They clear patients for surgery. They optimize patients for surgery so that iron levels, B12, TSH, all the hemoglobin A1C, everything is optimized. I want the patients to continue all their medications. For example, if they are on HRT, hormonal replacement therapy, the estrogen protection, I want them to continue on with that, because I don't want their system to go haywire before surgery. And that, I want them to continue all what they were. Now, if there are any supplements like ashwagandha or adrenal support or some other naturopathic medications, I do not know what's in them. No one knows what's in them. And so there is some uncertainty. God knows where they're made in China. Or South America, they are not regulated. So I do not want you to take something that may up the potassium, or they may cause more bleeding, if you will. So for that reason, I want the ladies to stop these medications, such that you basically avoid the unknown. But if there's any medication given by an MD where you are taking vitamin D or calcium, that's important for bone health. If you have taking any of the levothyroxine or synthroid for the thyroid, absolutely take that. Blood pressure medications, absolutely take that. And this is where I will answer those questions in the pre-op, exactly what to take, what not to take. Also, you want to make sure that you remove the day before surgery. You want to remove all metal piercings anywhere in the body, because we don't want that to be an issue when the grounding pad is put on, because the bovie cautery is used just like in any surgery that's done. So we want to make sure that you have your compression socks on, as talked about, and that at least 8 hours prior to surgery that you have not eaten or drank anything whatsoever, not even a sip of water, because we do not want to have whatever's in your stomach go into your lungs. The other thing I want to mention here is you want to stop smoking at least 6 weeks before. You want to stop the marijuana as well. This is unfortunately relatively common, and so you definitely, for optimal results, but for the best results, I want you to, just like the standard of care, I want you to stop at least 6 weeks before, hopefully permanently, so that we have the best foot forward and the best chances for recovery. I want to go ahead and mention this. I'm very happy to state that we have not had any infection, maybe questionable. One lady from the Washington State area, she had a wound that opened up slightly because of the severe inflammation, and a general surgeon managed that patient and did swabs and determined it was an infection. Sometimes if you ask me for billing purposes, but overall the patient did well. But overall, there has been no case where I've had to take back for cellulitis, infection, or abscess. And we're very blessed to have a very nice facility and staff that is very, very hands-on. And we're very blessed to have, a very good post-op infection-free rate. So now it was a pleasure to talk again. There's a lot to talk about. I find where in the next few Facebook Lives we will have guests come on. So I have that nice patient from Alabama, so she's going to share her journey, what she went through in order to come to me. I have a plastic surgeon who is Italian. He started following me last year. He's actually one of the local plastic surgeons, so I'm going to have him be on. He started following me, and he will talk about breast implant illness as he learned it through my practice, so that we can hear what he has to say. And this is his subjective evaluation about what and how breast implant illness should be managed. Now remember, I will end with this. If you go to 10 plastic surgeons, 9 out of 10 plastic surgeons would feel uncomfortable doing the surgery. And this is where the surgeon needs to have that determination that, just like any surgery, someone, for example, with a gangrenous gallbladder or a ruptured appendix, it is hard surgery. Just like with a lot of inflammation that's present, the plastic surgeon must be adequately trained, mentally committed, respectfully, sincerely committed to removing the whole capsule and all inflamed tissue, and that he or she should very directly be removing the entire implant capsule, all inflamed tissue, such that all of it is removed, number one, and number two, all of it is tested. Do your homework, do it right, do it once, and see the high definition pictures and videos of the chest wall showing complete removal of the capsule, so that you have that peace of mind, that tranquility, that everything was removed and everything was checked. Thank you again. This is Dr. Khan, Executive Plastic Surgery.